Hi, everybody. My name is Mike Conlon. I am an epidemiologist at Health Sciences North Research Institute and a site director at ICES North. I wanted to present our project today on the association between telemedicine use and overall mortality and relative rates of health services usage among a matched cohort of lung cancer patients in Ontario, a population-based recurrent event analysis using administrative data. I wanted to quickly provide you with some information about ICES. One of the first is that they have a strong web presence, so you can Google ICES to get a lot of this information. So ICES holds a vast and secure array of Ontario's health-related data. Researchers have access to this data, and ICES holds a prescribed entity status under Ontario's privacy laws, which allows ICES researchers to receive large linked data sets. This slide shows some of the production across the ICES network in 2018-2019. Again, the ICES Central has been around for about 28 years. ICES North has been around since 2018. So it's a developing and growing network that we are excited to be part of. But there is a lot of established work already coming out of it. There are over 250 scientists, 230 graduate students that are accessing ICES data. Again, it has substantial data holdings, 98 of them. And the network now spans all the academic health sciences centers in Ontario. So a few quick points about ICES North itself. As I said at the beginning, it's an important partnership between the Northern Ontario School of Medicine, Laurentian University, and Health Sciences North Research Institute. It opened in 2018. ICES North is physically located on the third floor of Health Sciences North in Health Sciences North Research Institute. It has a physical space with the latest technology that will allow systems to connect with the remote access environment of ICES Central. When our place was built, we were the final build, and so we've got some of the latest technology. And so in addition to this sit-down space where some people can work out of, we also now have an opportunity to be able to provide at a distance through laptops. So we are pleased that we're going to be able to roll those out so that people can actually access the Ray Holdings and ICES North, but not have to be physically located at ICES North. If you wanted to find out more details about the holdings, the value labels, the names of the variables that are in there, you could Google ICES, and you would be able to, just through the website, click into all of the different fields. You wouldn't see the actual data, but you'd be able to see all of the metadata around it. So our project is the association between telemedicine use and overall mortality and relative rates of health services usage among a matched cohort of lung cancer patients in Ontario. It's a population-based recurrent event analysis using administrative data. I certainly want to acknowledge the collaborators who are from ICES, Health Sciences North Research Institute, the Northeast Cancer Center, the Center for Rural and Northern Health Research, and Laurentian University. So just by way of introduction, the use of telemedicine in northern and rural populations certainly has the potential to improve patient and provider access. And that access is often challenged by factors associated with geography and rurality. Lung cancer remains a major source of cancer morbidity and mortality in these populations, is frequently diagnosed at later stages, and often has poor outcomes. So the purpose of our study was to assess the impact of telemedicine use by oncologist specialists on two different outcomes: overall patient mortality and health services utilization, which we defined as emerged department admissions. And we looked at this in a cohort of lung cancer patients who received telemedicine access at some point during their care. And we wanted to compare them to a matched control group of similar patients who did not. So for our population-based retrospective matched cohort study, we used a number of data sources, and with these data sources, we were able to link them all together so that we were able to define our cohort of interest, people with lung cancer, and we were able to measure their health services utilization and overall mortality. We did it by linking through a number of data sources, and we've listed the data sources here. Our general approach to our statistical analysis really involved using standardized differences to assess differences between our lung cancer group that had OTN exposure and lung cancer group that didn't have OTN exposure. And we were using standardized differences to measure anything that was imbalanced. And then we were going to match to select an appropriate control group. To measure our time to event, our time to mortality, we used Cox proportional hazards models. And then we wanted to look at ED admission rates. So we used a recurrent event analysis to measure and to control for the repeated measures. Here are some selected results. So first, our table one. Our table one gives you the distribution of variables before matching and after matching. Our goal again is that we have control, so people who never had OTN, and we have cases, people who ever had OTN. They occurred throughout Ontario, but we wanted to measure potential covariates. We used standardized differences to see if there were large differences between the groups. And if there were large differences between the groups, we wanted to use matching. And what our matching ended up doing was taking cases and matching them to controls in such a way that the standardized differences across baseline variables were now balanced. You can kind of quickly see that in table one. If you see the before matching controls, there were 21,000 potential controls. There were 1,600 potential cases. After matching, there are 804 pairs that are balanced across all of these variables. For example, if you look down at the northern residence variable, you can see that before matching, very few of the controls were in northern residents, and a large proportion of the cases were in the northern residents. But after matching, our 804 controls were balanced with our 804 cases across proportions within northern residents. So for our 804 matched pairs, we now were looking at two different outcomes. One of them was the relative rate of ED admissions, and that's what's in table 2. And we found that for the adjusted values, when you adjusted for all 20 different variables that we had measured at baseline, there was no significant increase in the relative rate. There was when it was unadjusted, but when we fully adjusted, there was no significant increased relative rate of ED admissions. And when we looked at some other things, for example, like cancer stage, those were the kinds of things. So for example, if you were diagnosed at a later cancer stage, you were more likely to have had a higher relative rate of emergency department admissions, which seems to be reasonable. Again, there was no effect of OTN on increased emergency department admissions, but rural residents, even though it was fully adjusted, still there was an increased relative rate of ED admissions if you had a rural residence. Our table 3 presents some selected results for the mortality analysis. And again, looking at the adjusted column, ever OTN use was not associated with a significantly elevated hazard ratio. If we look at some of the other sort of selected variables, we can see something like cancer stage, for example. If you were diagnosed at a later cancer stage or you had a higher cancer stage, you were significantly more likely to have a higher hazard ratio, worse mortality. And then we can also see the northern residence piece where after we've adjusted for all of these other variables, if you happen to be a resident in the north and the north was LIN 13 or LIN 14, you have a significantly elevated hazard ratio. So here are 3 findings that we've come up with so far. The first was that there's substantial imbalance pre-matching across many of the covariates. I don't think that that's surprising, but by using matching, we can actually balance out the baseline characteristics so that when we're looking at downstream pieces, they're not going to be influenced, presumably by those that we've measured and controlled for. In our adjusted matched analysis, we didn't see an increased overall relative rate of ED admissions or poorer mortality between the OTN group um, when compared to a similar cohort of folks who had similar disease and similar stage, but did not have OTN use. The third thing was that the rural residents and the northern residents, there are still things that are occurring there that other folks have found with the increased use of ED in rural areas and the increased mortality if you're a northerner, and we define northerner as inland 13 or 14, are things that other folks have reported and that people are trying to get a better understanding of. So thank you very much for the opportunity to present some of our research and to talk to you about ICES. If you are interested in the opportunity, would like to move a project forward, or would like to get more information about how to move a project forward or become a scientist, please get a hold of us. There's an email address for you, and we'd love to talk to you and see if we could make something work. Thank you. Bye.